Шановні колеги, доброго дня.
Dear colleagues, good afternoon.
Доброго дня. Раді всіх вітати.
We're happy to welcome you at the conference on implementation of telemedicine counseling in case of medical abortion. This conference is carried out together with the Foundation Women's Health and Family Planning and very famous American organization Gynuity Health Projects, which is one of the leading organizations in the world in terms of implementation of safe TMA. I'm happy to see you all at the conference, and I hope that more people will join us. As far as I know, more than 400 people have registered to participate in this conference. And I would like to introduce our guests, international experts who will be working with us today. They are our very famous expert from Georgia, Dr. Tamuna Tsereteli, and Dr. Rodika Commandant, who is very well-known expert in Ukraine from Moldova. She worked with us on implementation of numerous initiatives in Ukraine, in particular WHO study on abortion and contraception in 2008 in Vinnytsia and in Donetsk Oblast, and also on project implementation, the project which was guided by WHO from 2009 to 2015. And very many initiatives we're going to mention today were implemented under support of wonderful experts, and in particular, Rodika Commandant. Also, today, we have our Ukrainian experts on board who are members of the working group. They are prominent scientists. I can see Valentina Kwashenko. It's really a real pleasure to see her here today. And she is one of the very famous experts in Ukraine in terms of implementation of the concept of safe abortion and staff training. I don't see on the list who else is here, but we will see it. I'd like to give the floor to our technical experts, those who provide technical support to the conference. They will instruct you on using interpretation option and the questions, etc. So Andrei or Irina, please, over to you. Good afternoon, dear participants. Greetings to all of you. So with regard to interpretation, our trainers, our speakers will be delivering their presentations in English. In the bottom screen, you have an access panel, and there is a globe-shaped button on it. And it's written interpretation there. So After you press this button, you can select the language channel. Secondly, my another request to you is to change your names, to rename. Please rename yourself. If you don't know how to do it, we can do it for you, right in the chat, because some names are not quite clear. This is important because in the end of the conference, you'll be provided with a certificate, and we need to know your names in order to identify you. And this is all for now. If you have any questions, you can write them in the chat box, and we will trace all the questions and provide the answers. Thank you. Thank you. Andriy, can you prepare the presentation? And I would like to, well, actually, I've made my introductory speech. I've introduced our participants. So the name of the conference is a safe abortion in Ukraine during war time. And it's true now we're experiencing a full-scale war, and things we are going to discuss. This means that the system is working, that we're all here, we're all on our workplaces, we're ready to improve our health system, and we are protecting the interest of a woman, her reproductive and sexual rights. And today we're going to talk about safe abortion during the wartime in Ukraine. But we will go back to the history which happened 12 years ago. And we will speak about how the concept of safe abortion was introduced in Ukraine and at which stage we are now. I'd like to say that it's really important that today our partner is with us, and the next presentation will be made by Gynuity project. The drugs for TMA were registered in Ukraine in 2005, and starting in 2005, together with the Minister of Health, we were trying to engage our experts to this initiative, and the organization Gynuity Projects joined us also. And thanks to this organization, a lot of great things happened in Ukraine, including staff training, research, and Tamuna will elaborate on that a bit later. We continue working together, and today we will be discussing what is not yet in place in Ukraine. This is about telemedicine technologies implementation. At the moment, they're not included in our national guidelines, but this is the future. And we want to familiarize yourselves with the world experience, with what's going on in other countries. And in our neighboring countries, such as Moldova, which is helping Ukraine a lot during the wartime, and our American partners and other countries. I'm sure it'll be very interesting. So that's why I'll start with my presentation first. In Ukraine, in 2010, we had almost a revolution. One of the first ministerial orders, according to the new standards, was comprehensive care in case of unwanted pregnancy. It included the leading experts from the WHO, and we had very powerful expert group in Ukraine, almost 20 experts. And looking back at what happened 12 years ago, I understand how many problems were in place which had to be solved. They included the issues regarding dosing of well-known mifepristone, because at that time high dose was promoted, but now it's not. There were a lot of discussions whether it will be inpatient procedure or will it be home-based procedure. So I should say that that protocol was quite difficult to adopt. In 2013, the Minister of Health issued order number 423. By that time, a lot of things had been done, and the new recording and reporting forms were developed. Next slide, please. The ministerial order number 378, dated 2007. This is the statistical reporting number 13, the report on abortions. We also used this form, and we had a lot of difficulties in terms of recording medicated abortion. Now, this is the official statistics provided by the Minister of Health. We used it. And to begin with, in 2011, officially in Ukraine, there were registered 163,668 abortions. Now we have 46,992 abortions that were officially registered. Does it reflect the reality? I'll show you the data, which are quite hard to interpret, but please have a look. So regarding the use of the methodologies. So actually, on one hand, we're happy with these indicators. So heritage 5.6%. When we were starting WHO assessment in 2007, the level of DNC was more than 65%. And after 14 years, we have 5.6%. I don't know how reliable these numbers are, but still we can see the significant reduction. Also, the vacuum exfoliation, it still exists, and aspiration as well, they're still in place. But if you add all these numbers, we won't get 100% here. Officially, 10.4% of medication abortion were registered. But I think this does not include the numbers from private facilities. Many people don't report on this kind of abortion. So I think this percentage is much higher. Next slide, please. So I'd like to note a high percentage of unspecified abortions. And going back to the statistics, there is a question, what is it? So this can be spontaneous, this can be stillbirths, and we can see this stable percentage in the second trimester, or even incomplete second trimester, late abortions from 12 to 22 weeks. And this is the percentage which is basically at the same level. We don't have criminal abortions. They're not registered in Ukraine. And we don't have maternal mortality due to criminal abortions. But the conclusion is that if you try to add these percents, we won't have 100%. There are there's huge bias in there, and this is a big question, which brings us to the system of data collection and interpretation. And these data do not reflect the real picture. And it seems to us that medication abortion, other interventions. If all this was fully funded by the state, I mean, the procurement of the drugs, the provision of drugs to the patients, I think in that case, the statistics would look completely different. But you know that today, irrespective of the last year, we should be aware that medication abortion takes place at the expense of a patient, and it is not covered by the state. Unfortunately, we can say that those 2% of abortions in the second trimester, quite often they are also paid by patients, even though this service is supposed to be provided. And
Let me also emphasize that we still have the war in our country. Nevertheless, we are still working on this subject because it's critical even in the current day agenda. And here I'd like to explain a very significant shifts which are taking place. First of all, since the start of this year, we have a working group under the Ministry of Health of Ukraine, which has brought together, I believe, the best professionals in Ukraine. And they are working to update, actually to renew some of the fundamental legislation, clinical guidelines, and operational procedures. As you might remember, the most recent WHO guidance was not reflected in Ukrainian legislation because most recent Ukrainian legislation is dated by 2013. So the clinical guidelines have been translated and adapted to the Ukrainian realities, but this is basically the edition by the World Health Organization. And we believe that soon enough they'll be made available for public access. And also we are finalizing the standards of care for medical abortion in the first trimester, which does not exclude either curettage or some other barbarian techniques. So medicated abortion and vacuum aspirations would be the only options considered. And emphasizing once again, the outdated regulations will expire in September this year, and soon enough we will have the new edition of the regulatory framework for medical abortion. Now, the group is also working on the second trimester guidance, and soon enough these documents will be publicized, at least made available for public discussions. Speaking of our contribution, and we are representing the International Federation for Family Planning, I have to admit that now there is a lot of attention focused by the donors, namely on Ukrainian case, not only in terms of military support, but also in the area of humanitarian sector and healthcare as part of it. We are working together with the International Federation for Family Planning, with the UK government. We also are collaborating with the UNFPA, who in their turn provide us with different types of support so that we can reach out to different healthcare facilities. And that's where and why we tried to and succeeded in developing a 5-day long training on medical abortion, including medicated abortion, manual vacuum aspiration techniques, and this will be offline event and where we spent full 5 days working with the clinicians in some of the pilot regions. We have started in Khmelnytsky Oblast, Vinnytsia, Odessa, Kirovograd, Kyiv Oblast, and Poltava Oblast. So these are 6 pilot regions. I believe Today, we have a different focus in our conference, but this is just to mention that we are providing a lot of assistance in collaboration with the local medical universities, which are part of continued professional development courses, which means that all of our course attendees receive attendance certificates. Further on, I'd like to also describe in greater detail something that is important because we are coming back to medical manual vacuum aspiration, which has been neglected in the recent years, and thus these in-depth trainings that we have conducted, remembering also those that we conducted between 2009 and 15. So again, these are just a couple of snapshots. You can scroll a couple of slides further on to show our efforts and accomplishments in teaching and training the new generation of practitioners. So we have procured some special simulation devices. And Radhika, you know this perfectly well because you've been one of the organizers of such trainings with involvement of the patients at the time when it was available, but now we have to simulate such trainings. Next slide, please. Next one, please. Excellent. Also, there's been a lot of medicines that have been handed over with the support of our partners. And here, please pay attention because this is important. Back in 2022, when the war started, in the month of April, with the support from Gynuity, and Tamona will be presenting today, and we thank her for her personal contribution. But the fact is that we received humanitarian supply soon enough after the war started. And that was really a lot. We received 1,200 kits for medicated abortion, and these supplies were distributed to Vinnytsia, Poltava, Dnipropetrovsk, later on even to Rivne Oblast as well. But this is just to mention that it's is not a focal point for discussion in our today's conference, but these kits, these drugs were made available to the patients and they could attend to themselves. Further on, I also would like to report that we have shared 48 kits for medicated abortion, including misoprostol, mifepristone, and we are not talking about 3 to 4 dozens such kits because each kit includes 300 pills, which means 300 people who receive the recommended dose. So this is a huge amount of assistance shared with the patients. And if you are interested in more specific details, we'll be happy to provide you with our distribution report to make sure that you can see who beneficiaries are, but this covers our pilot regions. But also there were 32 kits, the so-called kit of 8, which was supported by UNFPA, but we had to procure it using our own funds. And today we'll be monitoring the efficacy of use of such kits because we believe that everything was delivered to the actual beneficiaries and shared with the patients. Further on, we have established, we call them gynecological offices for reproductive health. But in fact, these are reproductive health clinics because that is something that we've been establishing between 2009 and 2014, where we've been refurbishing some space, providing for equipment, installing the equipment, including some micro surgical theaters for vacuum manual or electric kind of aspiration, making sure that these spaces are both provider and patient friendly. And today we are planning to scale up the coverage with such microclinics because now we have two of them open in Odessa in the perinatal clinic number 7. Looks like the speaker has muted herself. Something wrong has happened with my device. So additionally to Odessa, this is also Vinnytsia Oblast clinic in Vinnytsia, and Heightened is also one of the sites in Vinnytsia Oblast. And just to describe what that means, this is how these reproductive health offices look like. So you can see the equipment, the refurbishment, and the setup provided. So they are well equipped to make sure that even people who require inclusivity settings, being people with different disabilities, they also can seek and access care in these locations. This is another example of such refurbished office. This would be examination room. So there might be some differences in terms of layout, but equipment is basically the same in all cases. So you can scroll a couple of the next slides with additional snapshots. And this would be the patient admission area. So the patient can rest for a couple of hours, additionally to the counseling rooms. Also, I'd like to report that altogether we have delivered over 15,000 different services. And this is not only family planning, but that number also includes 12 women with disability. And the number of internally displaced people was high enough. And this is only the first quarter of the current year. Also, I'd like to emphasize the importance of delivering the safe abortion counseling sessions. Additionally to 96 medicated abortions, 36 vacuum aspirations, over 10,000 of counseling sessions for contraception, and 1,000 of counseling sessions for reproductive health, which means that we are not using these microclinics for abortions only. This is really a center of comprehensive services, including counseling of different women's health associated subjects, including family planning and abortion. And these are some of the examples of handout materials which bring together a lot of helpful information. The first one about artificial abortion, which is a very interesting publication, and it serves as an aid in counseling activities. Also, we've been distributing brochures about different contraception techniques, focusing on the young people, and also some special calendars, quite big size tabletop calendars with helpful reminders and tips for contraception and family planning. So this helps us to abide by the fundamentals of comprehensive case management, which is quite helpful in terms of preventing future referrals. And to finish my presentation, I'd like to emphasize another important point, which was disputed at a very high level in the domain of reproductive health, which was Berlin-based conference. And in fact, Ukraine is not the only country which is affected by armed conflict and a humanitarian crisis. But what makes Ukrainian case so specific and even non-conventional is that we are attending to our humanitarian needs, but at the same time, this is not done at the cost of our development. That means that we continue our intensive efforts to improve Ukrainian legislation. And this is done in the context of war. This is done under the shelling. And we have members of our working groups, both in Kyiv, in Zaporizhia, in Dnipro. All of them are suffering from the air and missile raids and terrorist attacks against the civilians. But we are still working productively, manifesting the best of our commitment and will for the best benefit of improving our capacity to serve our patients to the best. If you have any questions or contributions to my presentation at this moment, do let me know. I'll be happy to answer. Otherwise, please save them for the Q&A session at the end of our meeting today. But looks like I have saved a couple of minutes of my time slot for the benefit of questions and answers. So do feel free to ask any or spell them in the chat, please. Also, let me make sure that you can hear me well and also confirm that translation is working, just to make sure that we hear each other. And do we have any questions in the chat, maybe? Not at the moment. I hope that means that my presentation was comprehensive and clear enough. And if there are no questions, then let me hand over to Dr. Tamona Tsaretelli, who will be our next key speaker in the conference. She is a project coordinator of the Gynuity for the Eastern Europe and Middle Asia region, and she has tremendous amount of experience working in our countries as well as in the global research. And I have to admit that we had the pleasure of enjoying our participation in two major conferences held in Georgia. If I remember this correctly, their most recent event took place in 2016. Tamona, please correct me if my memory is failing.
Yeah, that's absolutely correct, Galina. And actually, I will be talking about our regional conferences.
Так,
Yeah.
і остання відбулася в Україні, здається.
Excellent. And speaking of Ukrainian conference, I believe it also was 2016. But again, I don't want to steal any of your time, Tamona. So welcome. And if you're ready for your presentation, we are all ears and our attention will be with your presentation.
Yeah.
Thank you.
Yeah, thank you so much, Galina, for introducing me to the audience. But I do believe there are some participants who collaborated with us and who are familiar with Gynuity Health Project. So I will use like 10-15 minutes to introduce Gynuity Health Project to the audience. And first of all, I would like to express my gratitude for such a big interest, such a huge interest in telemedicine medical abortion, which is innovative approach to deliver safe abortion services. So, Gynuity Health Project is a non-governmental organization that was founded 20 years ago by Professor Beverly Winikoff. And I would like to say that Professor Beverly, she will join our conference by the end, and she will be talking about telemedicine medical abortion globally. Mission of Gynuity Health Project is to develop and advocate for the use of scientific, clinical, and programmatic evidence in reproductive health and maternal health globally. Gynuity conducts clinical research and service delivery research studies all around the world. We conduct trainings for medical providers in medical abortion in the first and second trimesters, and we also provide technical assistance in developing and or revising national guidelines to different countries. And Gynuity advocates for the use of not only telemedicine, but safe abortion services globally. Next slide, please. Next slide, please. So our organization works in different areas of reproductive health. We work in medical abortion. We work on issues of pregnancy and birth care. We work on prevention and treatment of postpartum hemorrhage and preeclampsia. We work in contraception, and especially contraception after abortion, including both medical and surgical abortion. And our organization worked in different areas of infection disease in reproductive health. Next slide, please. So far, Gynuity worked in 71 countries all around the world. And you can see on the slide that our organization worked in all continents. As for the Eastern Europe and Central Asia, we work with colleagues in different countries, including Eastern Europe. We work with colleagues in Ukraine, in Moldova. We work with the colleagues from Caucasian countries, Armenia, Azerbaijan, Georgia, and we work in Central Asia, in Uzbekistan and Kazakhstan. Next, please. Next, please. So our collaboration with the colleagues from Ukraine started in 2005. And during these 18 years, we conducted and disseminated clinical research studies, 5 clinical research studies. Out of them, 4 studies were medical abortion in first trimester. 3 first studies were just to simplify medical abortion, to give a choice to women to select where to take the medications, mifepristone and misoprostol. And the last study that we conducted, it's on telemedicine medical abortion. And after this presentation, I will be sharing findings of this study. We also conducted clinical research study on the second trimester medical abortion, and we worked with the colleagues in Ukraine, in Kiev, Poltava, Vinnytsia, Lviv, Odessa. Next slide, please. In addition to conducting clinical research study and disseminating the study results, we also conducting medical abortion training for the first time medical abortion for providers in the Kiev and in the regions. We conducted second trimester medical abortion trainings for providers in the capital city of Kiev and in the regions. And I would like to highlight that in our trainings and in our studies for the second trimester, nurses were included. They attending the trainings, and they were part of the clinical research studies. And in 2015, Gynuity conducted a 2-day seminar on safe abortion with participation of international experts. This conference was attended by 60 participants from Ukraine, from different regions. And during the 2-day seminar, we talked about the first trimester medical abortion, second trimester medical abortion, about the challenges there are in the countries, and about the achievements that was done by the time in Ukraine. Next slide, please. In addition to all these activities, and Galina just mentioned about the regional meetings, Gynuity organized regional meetings. Twice regional meeting was organized in Tbilisi, Georgia, and in 2012, the meeting was organized in Istanbul. This meeting was attended by the participants from all countries from Eastern Europe and Central Asia, as well as participants from Western Europe and America. During this 2-day conference, participants had a chance to share their experiences in the first trimester, in the second trimester, and to talk about the steps and about the activities that should be done in each country to improve women's access to safe abortion services. In 2013, Gynuity organized a panel session at European Society of Contraception in Denmark, Copenhagen, and our colleagues from Ukraine participated at the panel. Dr. Galina Maestruk spoke at that panel, and she shared with audience about the situation with regards of safe abortion services in Ukraine, challenges and achievements that was done so far. In addition to participation in the regional meetings and the conferences, our colleagues from Ukraine participated at Mifepriston medical abortion meeting that was organized annually in New York City. Our colleagues from Ukraine participated in 2010, 2015, and 2017. This meeting usually gathered colleagues from around the world, from all continents, and our colleagues from Ukraine had a chance to talk about their experiences and to share their experience with the colleagues from different countries. Next slide, please. All clinical research that was conducted in Ukraine, and I can say that elsewhere, usually we prepare the manuscript for peer-reviewed journal, and on the slides you can see the publications, you can see the results of the first trimester medical abortion and second trimester medical abortion that was conducted in Ukraine, and our colleagues from Ukraine, they are co-authors of these publications. Currently, we are working on the publication on telemedicine medical abortion in Ukraine, and our Ukrainian colleagues, they will be co-authors of this research paper. So thank you so much for your attention, for your time. This is just briefly to talk about Gynuity Health Project. And if you have any questions, yeah, please.
Шановні колеги, якщо є запитання,
Dear colleagues, if you have any questions, please feel free to ask them. I noticed that somebody raised his or her hand, but I can't find it now. Colleagues, who?
173 учасники.
We have 173 participants, and it's quite difficult to find those with raised hands. Please, those who raised hand, if you could do it once again, please. Maybe it was accidental. An accidental hand. Okay. Okay, we don't want to miss any questions, any people who would like to speak on this subject. We have time for questions. Yes, we are tracking the chat box, and we won't miss anyone. Okay. I think if there are no questions regarding these two presentations, now we will speak about, sorry. So no raised hands. So if there are no questions with regard to first two presentations, Tamuna will speak about the implementation of the research regarding TMA. This is a short, this is a small study, which is not commercial. This is the research project, which again is not commercial. And that's why it's very important for us to hear about this project, and let us see the next presentation. And I think this will provide us with with great information about telemedicine. Over to you, Tamina.
Yeah, thank you. So, dear colleagues, now I would like to share with you the findings of our clinical research study, Safety and Acceptability of Telemedicine Medical Abortion Service using the No-Test Protocol in Ukraine. Before starting the sharing the study results, I would like to talk briefly about the medical abortion procedure that is typical in most of the countries. The medical abortion procedure is outpatient procedure, and although it happens in clinic. A patient needs to come to the clinic. She needs to have some pre-abortion tests and exams. In many countries, ultrasound is required, and the patient should have ultrasound diagnosis to receive the medical abortion service. So after reviewing the test results and ultrasound diagnosis, provider made an assessment of eligibility for medical abortion, and if a woman is eligible, she provides counseling. During the counseling process, she or he, medical provider, provides all details regarding how to take the mifenyzole pills, what to expect, what are the side effects, what are the complications, and where to seek additional care if there is a need. After counseling, woman receives medication. She receives 1 mifepristone pill and 200 microgram misoprostol pills. In total, she receives 800 microgram misoprostol pills. Despite that, most of the international recommendations like WHO, FIGO, they don't recommend follow-up assessment, in-clinic follow-up assessment for uncomplicated medical abortion. Most of the providers, especially in our region, they ask women to come to the clinic after 10-14 days of mifepristone administration for in-clinic assessment. And usually at clinic, ultrasound is performed and diagnose the status of abortion procedure. So this is the typical medical abortion process that occurred in many of these settings. Now I would like to talk about the telemedicine. Next slide, please. So what is telemedicine? It's a use of telecommunication tools like phone, texting, email, video conference to provide one or more aspects of abortion procedure, such as counseling and eligibility assessment, provision of medical abortion pills, and guidance and follow-up assessment. There are two models of telemedicine medical abortion service delivery. One is called direct-to-clinic telemedicine medical abortion. In this case, patient is in a clinic and the provider is in another location, and patient receives remote consultation. After providing the counseling on medical abortion, woman gets mifepristone and misoprostol pills in the clinic. In other case, which is called direct-to-patient telemedicine medical abortion, patient is at home, she receives remote counseling on medical abortion, and abortion provider is in a different location. And woman after counseling gets medical abortion pills by mail or courier services, or she can pick up the medications in clinic, or she can get the medication with prescription at the pharmacy. Next, please. Remote provision of medical abortion allows for telehealth visits for eligibility assessment and follow-up assessment. However, pre-procedure tests still require patients to go to health facility, either to have some lab tests before procedure or to have ultrasound to diagnose the intrauterine pregnancy and to make an gestational age assessment. And my colleagues at Gynuity, during the crisis period, during COVID-19 restrictions, they developed so-called no-test protocol. And the aim of this protocol was to reduce in-person contacts exposures during the pandemic. And this protocol uses either mifepristone and misoprostol or misoprostol on the regimens. And using this protocol, women can get medical abortion procedure without unnecessary pretreatment in-person exams. So in this slide, you can see that this no-test protocol is available on Gynuity website, and you can see this protocol in different several languages. Next slide, please. So the objective of our study was, the goal of our study was to pilot and evaluate a telemedicine medical abortion service delivery model that allows remote communication between the woman and provider, and which limits medically unnecessary in-person visits to the clinic. And the objective of our research was to obtain data on safety, feasibility, and acceptability of a telemedicine medical abortion service delivery model using the no-test protocol in Ukraine. Next slide, please. Our study was open label pilot observational study, and our study happened in 2 rounds. It was 2 phases of the study. During the first phase, the study started in September 2021, and we enrolled women until February 2022. And we resumed this study in June 2022 till November 2022. And the sample size of this clinical research study was 120 women. During first phase, we enrolled 40 women, and during first phase, only 1 clinic in Kiev participated into the study. During the second phase, there were 2 study sites. The study regimen of our clinical research study was 200 milligram mifepristone, followed by 800 microgram buccal misoprostol. And as I mentioned, there were 2 study sites: Clinic Врачебные традиции в Киеве and Regional Clinical Hospital of Rehabilitation and Diagnostic of Poltava Regional Council in Poltava. Next slide, please. So I would like just to briefly how was the design of our study. Women who contacted our clinical research sites in Kiev and Poltava received the information about telemedicine medical abortion study. If women were interested into telemedicine service delivery, they had phone or video consultation with provider. So before contacting the study sites, women already diagnosed their pregnancy, either by using urine pregnancy test or by ultrasound. But if patient still needed some screening test, she was referred to nearby clinic. I would like to highlight that she was referred to nearby clinic, not to the study site, to obtain some clinical tests. And the results of these exams were sent to the provider. After making final assessment that medical abortion was eligible for the woman, provider provided counseling on medical abortion, included all details about the medical abortion procedure, how and when to take the mifepristone pill, when to administer misoprostol pill, and what should be expected, bleeding, pain, what to do in case of pain, and all the details of medical abortion procedure. And after counseling, provider sent package with medications. So this package included included 1 mifepristone pill and 4 misoprostol pill. And in addition, this package included the instructions how to administer drugs and where to seek additional care if there is a need. After administration of mifepristone, after 4 weeks of mifepristone administration, each woman was instructed to have to take urine pregnancy test, and after this, woman received the call from the provider, and provider made a follow-up assessment of abortion status by video or phone call. Next slide, please. So I wanted to talk about the no test protocol. So how we make an assessment of eligibility. First of all, pregnancy should be confirmed. It should be confirmed either by using ultrasound exam or urine pregnancy test and menstrual history. So last menstrual period, the maximum gestational age according to this no test protocol is 77 days, but in our clinical research study, the maximum gestational age was 63 days, which is in line of the laws and regulations regarding the outpatient medical abortion services in Ukraine. So patients should be certain about her last menstrual period plus minus 1 week. There should not be symptoms of risk factors for ectopic pregnancy, and for sure, they didn't have contraindications for medical abortion. I would like to mention that our clinical research study protocol and all instruments that were used during collecting the information was reviewed by ethical committee board at Ministry of Health, and we received an approval to conduct the study in Kiev and Poltava. Next slide, please. So in a no test protocol doesn't require RH typing. Actually, patient whose pregnancy is up to 70 days gestational age, they don't require. But if we look at the new WHO guideline, which was released last year in March, so there is a new recommendation number 8, that says that RH isoimmunization for abortion at gestational ages less than 12 weeks is not recommended. So there is no recommendation to have anti-D immunoglobulin administration, and it's for both, for medical and for surgical abortion. So our study participants, we didn't require for RH typing. Next slide, please. So the study regimen and study treatment in our clinical research protocol was 200 milligram mifepristone, 1 pill of mifepristone, followed by 48 hours, 800 microgram miso, which means 4 pills of misoprostol buccally. So in our study, we used on the buccal route of administration, but no test protocol allows buccal and vaginal routes. In no test protocol, you can find that in case if gestational age is more than 63 days, there is recommended a second dose of misoprostol, 800 microgram misoprostol after 4 hours, after 4 hours of the first dose. But if the pregnancy is less than 63 days of gestation, second dose of misoprostol is recommended only in those cases if there is no bleeding within the first 24 hours after the first misodose administration, or if there is clinician's judgment. Next slide, please. So how happens follow-up using these new technology tools for telemedicine medical abortion? So after 1 week of taking mifepristone, medical abortion provider contacts women, and if there are no indicators of ongoing pregnancy, she instructs patient to take urine pregnancy test 4 weeks after mifepristone or misoprostol administration. If there are some signs of continuing or ectopic pregnancy, patient is asked to visit clinic for ultrasound diagnosis or for serum HCG. 4 weeks after taking misoprostol, women should take urine pregnancy test, and if first urine pregnancy test is positive and there are indications of continuing pregnancy, she is asked to come to the clinic for ultrasound diagnosis and for or serum HCG and for some additional care. If the urine pregnancy test is positive, but there are no indications for continuing pregnancy, woman is asked to have additional urine pregnancy test after 1 week, which means she is taking second test after 5 weeks from mifepristone administration. And if the pregnancy test is negative, so there is complete abortion, but if second urine pregnancy test is positive, so she should come to the clinic for ultrasound diagnosis or for serum HCG. Next slide, please. Now I would like to talk about the participants' obstetric history, about the history of women who participated in our study. As I mentioned, we recruited 120 women. 40 women were recruited in Poltava and 80 women were recruited in Kiev. All women were of reproductive age with median age 32 years. Most of them had previous deliveries, previous pregnancies, and I would like to highlight that only 6% of our participants had the previous experience of medical abortion, and the median gestational age of pregnancy of our participants was 44.5, and the gestational age ranged from 28 to up to 63 days of pregnancy. Next slide, please. Most of our participants were from urban locations and just only 12% from rural locations. However, it's quite interesting to look at the travel time to the clinic and distance to the clinic. You can see that median travel time to the clinic is 42 minutes, but the range is quite huge from 15 minutes to 150 minutes. And the distance to the clinic, the median is 18 kilometers, but some women needed to travel 2 kilometers, and there were some women who traveled quite a long distances, even up to 120 kilometers. Actually, they didn't travel. They had all this remote communication with the medical provider, and they received medications. I will talk about this right now. Next slide, please. So our participants can use the several modalities for telemedicine medical abortion, and the most popular was cell phone. The vast majority of our participants use cell phone, but they were using some mobile apps too, like Viber, WhatsApp, or Telegram. These cell phone apps especially were used for sending signed informed consent. So all our participants to participate into the study signed informed consent. So this informed consent was sent either by mail or through this WhatsApp, and provider received the signed consent from the women. Most of our women, most of our participants were with high school education, and more than half had full-time job. Just we had few women who were students or who didn't work. Next slide, please. After providing the counseling and after inviting and including all these women into our study, into the telemedicine medical abortion research clinical study, our study providers, they asked about the reasons for interest in telemedicine medical abortion. And the women, our participants, could choose more than one answer. And most frequently reported reason for the interest in telemedicine medical abortion was convenience, fewer missed days of work or school, and to avoid travel to a clinic. Next slide, please. During the first call, during the initial call, each woman was asked, and provider and woman, they discussed the method of obtaining medical abortion pills. And in most of the cases, pills were delivered by courier services or were mailed. In about 1/4 of the cases, women picked up the medical abortion medications in person at the clinic. In 15% of cases, the medical abortion medication was delivered by clinic staffs, and there were just few cases where our participant husband picked up medication, or in 3 cases, women used the taxi services to get the medications from the provider. Next slide, please. Now I wanted to talk about the telemedicine medical abortion service delivery and feasibility. We wanted to see if there are any kind of problems or on sending and receiving the drugs. So medical abortion drugs were delivered the same day as the initial call in most of the cases, in 114 cases. All 6 cases where there was some delay and they were sent on the next day. All these cases occurred during the second round in Kiev, so it occurred after February 2022. Medical abortion drugs were received the same day as delivered, and we also wanted to look if medical provider contacted women at scheduled follow-up time as was scheduled during the initial call. So provider spoke to the patient at the scheduled 1-week follow-up time in almost all cases. Just in one case, and there was a woman in Poltava, she went to another facility before 1-week follow-up call because she didn't have any bleeding, and she went to another facility. She was diagnosed with ongoing pregnancy and had surgical intervention. So providers spoke to the patient at scheduled 4-week follow-up time. Almost for all women. You can see that just only 6 women were not contacted at the scheduled time, and actually all these women, all the 6 women, they were referred for in-person visit due to some symptoms of incomplete abortion. They were referred either to the study site or to another facility. And none of the women in our study reported problems receiving medical abortion drugs. So we can say that all these modalities of sending the medical abortion drugs to our participants worked quite well. Next slide, please. So the success of medical abortion in our telemedicine medical abortion was the same as we see in literature. Efficacy was quite high, about 96%, and only 5 women out of 120 had surgical intervention due to incomplete abortion. And final abortion outcome was confirmed remotely by urine pregnancy test and patient symptoms checklist for quite a huge number of participants, for 90% of participants. So in our study, in our telemedicine medical abortion study, we also looked how many women came back to the clinic for some reason, how many women they were referred by a provider, or there was a patient request. So you can see that just one woman came to the clinic before 1 week follow-up call. 6 women, they were referred after 1 week follow-up call. And there were 12 women who came back after 4-week follow-up call, and it was patient request. Despite that, study provider, so she diagnosed complete abortion based on urine pregnancy test result and patient symptoms. These women required to come back to the clinic for an ultrasound, and all of them had ultrasound exam, and in all cases there was complete medical abortion. And I would like to highlight that we didn't have any single serious adverse event in our clinical research study. Next slide, please. After diagnosing complete abortion, either remotely or at clinic, each participant was interviewed by our study providers. And they were asked about their satisfaction with telemedicine medical abortion service delivery model. And 96% of participants reported that they are either satisfied or very satisfied with the telemedicine model. And you can see that there were just few percentage of women, 2%, who were either neutral or who were unsatisfied with remote provision of abortion services. Next slide, please. We asked participants about their future preferences, and most of the participants, 90%, they told that they would select telemedicine medical abortion for future abortion service as a future abortion service delivery method if there will be need. And just quite a few women, about 6%, they told that they do prefer to have in-person abortion procedure. And the vast majority of our women, 81%, they would recommend to telemedicine medical abortion services to a friend. Next slide, please. We also look how well women understood all those instructions that were provided remotely by medical provider. And all our participants, 120 women, all reported that they took mifepristone before 64 days of their last menstrual period. Almost all women took all four misoprostol pills after 48 hours of mifepristone administration. And only one woman took miso after 48 hours of taking mifepristone. And vast majority of our participants took urine pregnancy test before providers 4-week follow-up call. And so there were 6 women who didn't have this UPT at follow-up call because they were diagnosed with incomplete abortion and they were not contact. And there were just only 3 women who went to a nearby facility for ultrasound exam to have diagnosing of abortion status instead of having a UPT at home. Next slide, please. We also asked our participants what were the best and worst features of telemedicine service delivery. And as the best features, women could choose up to 2 responses. And as the best features, the most frequently reported best features were convenience, missed less work school, privacy, and no need to arrange a childcare. Most of the women, they reported that there are no worst features of telemedicine medical abortion, and just there were few responses that the worst feature of TMA is that patient doesn't see a provider in person. Next slide, please. So in our clinical research study, there were 120 participants, and out of them, only 20 participants, which is about 17%, 20 women had in-person visits to the study clinics. 1 woman came before a 1-week follow-up call. 2 women were referred by the provider after 1-week follow-up call, and 12 women, as I mentioned already, requested to visit clinic in person after a 4-week follow-up call. And 5 women had unscheduled visit after a 4-week follow-up call. So, and I also wanted to say that 5 women had in-person visits to an outside facility. So in total, 100 women had a complete abortion confirmed based on urine pregnancy test result and symptoms, and all of them avoided medically unnecessary in-person visits to the clinic. Next slide, please. So based on our findings and based on our results, I want to make some conclusions. We can say that telemedicine medical abortion using the no-test protocol is safe and effective. Women are safely able to follow instructions provided remotely. Telemedicine medical abortion is feasible and acceptable for women in Ukraine. And telemedicine medical abortion has a potential to improve access to medical abortion services during a crisis period. And we all remember crisis period in 2020 during the COVID-19 restrictions. And also telemedicine protects women's safety during pandemic and during crisis period. Next slide, please. And by the end of my presentation, I would like to express my gratitude and to say huge thank you to all our participants, medical providers. And first of all, I would like to thank Dr. Galina Maestruk and Angelika Maznova from Charitable Foundation, Women Health and Family Planning for such a great assistance. Despite such a hard period, they managed, and our study went really smoothly, and we managed to complete our study. And I would like to thank our colleagues from Clinic in Kiev, Врачебные традиции, Vladimir Bannikov, Larisa Kulabucheva, Irina Arutunova, Alla Tukaeva, and Natalia Yureva, all these doctors and nurses who made a great job. And for sure, I would like to thank our colleagues from Poltava Regional Clinical Hospital of Rehabilitation and Diagnostics of Poltava Regional Council. I would like to thank Dr. Ludmila Ivanova, Ludmila Kasyan, Ludmila Dika, Lydia Pasichnik, and Natalia Yalova. Thank you all.
Тамуна, дуже дякую тобі за презентацію.
Thank you very much, Tamuna, for your presentation. And before I give the floor to the next speaker, we have 10 minutes and we have some questions. I would like to answer the first question. I think I will be able to do that. It is in the chat. Irina, can you read this question? I will read it. The first question was the following: who will be responsible in case of complications after administering the drugs? If, for example, the patient administered them incorrectly. And the second question is how to get the drugs if the patient is abroad. I would like to say the following. Today, we are having this online conference based on quite a small research. First of all, this is just the beginning. And Andrei, thank you. So first of all, I want to note that if you think about your practice of medical abortion, you will understand that 80% of your practice are related to telemedicine. Even people who don't know what telemedicine is, they still use it. Why? Because in 2007, we had the national conference where, thanks to such a small study, we were trying to say that a woman can take misoprostol at home, that she's not supposed to take it in the hospital, according to the current legislation. And there was a huge resistance to it from the part of the healthcare workers, from the health providers. How come we allow a woman to take drugs herself? And it appeared that a woman takes a pill in your office and then you let her go home. And at home, she takes the rest of the pills. And she is in contact with you all the time. You're counseling her, asking her questions, and she all now women can use their cameras. They can send you pictures, and you respond. If, for example, a patient has complications. In this protocol, you can see that we worked mostly with women from urban areas, from the cities, and it took them maximum 40 minutes to get to the clinic. Most of the women were with higher education. That's why, and this is just the beginning again. This is not the guideline which makes you do this. At the moment, this is just the basis to start the discussion how we can use these technologies in Ukraine in case people cannot reach the clinic, if they are far away, or if COVID comes back, for instance. When a person comes to your clinic and is at risk of contracting COVID, or as you understand, this is the issue for critical situations. But I'm sure that you all use telemedicine to a certain extent. And it doesn't mean that in your practice you should not see your patient, for example, at the beginning of, at the time of diagnosing. This is all possible. She can undergo ultrasound, etc. That's why the question about responsibility, we are all responsible for that. But basically, we already are using telemedicine. For me, the biggest issue in Ukraine is where will patients get medications? For example, during the study, we didn't have any problems because we had the drugs provided free of charge. And then we could give these drugs to people who participated in the study for free. Now the question is, where would people get the drugs when they will have to buy them? Will it be possible for them to buy drugs in the pharmacy? That's another big question. And I think these are key questions for Ukraine. How will we be able to organize the distribution of these drugs? But this method is working, and even with the sample size, 120 patients, you see nothing horrible happened. The question about buying drugs abroad, I would say that it's different in every country. You know, in Poland, abortions are prohibited completely, and people who are in Poland, they either come back to Ukraine or go to neighboring countries such as Germany or Czech Republic to get these services. So I don't know how to answer this. I think most important question is, what shall we do in Ukraine?
Yeah.
And I think we will have also a chance to speak with Rodika Commandant. I think she will share her experience of how they solved this issue in Moldova. I can see that she raised her hand, and I would like her to share this with us. Over to you, Rodika.
Thank you very much, colleagues. I will speak in English. So first of all, I would like to congratulate you with such a nice results of the study. Good for you. You are following the WHO, the most recent recommendations from 2022 to add an alternative way of service delivery via telemedicine. I want to say that such experience you heard from Tamuna happened in Azerbaijan, in Uzbekistan, coordinated by Gynuity Health Projects. We in the region started the similar project pilot study in Kyrgyzstan, and they practically completed the enrollment, and they would like to extend the number of enrollments also with very good results. Another country is Kazakhstan, which is also willing, the country team, to do a pilot study. Meaning that there are many attempts, many countries which are now ready to proceed to the test of the telemedicine for medical abortion. And I would like also, thank you, Galina, for mentioning Moldova, to share very quickly that we conducted a similar study in Moldova, but we started in March 2020, when the pandemic started. And it was absolutely impossible for many women to have access to safe abortion. This is why instead of 200, we enrolled practically 500 with a very good results, 98% efficacy, very low level of complications. And because we were in the pandemic and we were updating our national protocol, in 2020 in August, we introduced medical abortion via telemedicine already in the national protocol, national standards, which can be one way how to scale up, how to disseminate these good results on the country level. Another way, what we do, so this was like a vertical scaling up, like WHO recommends. Horizontal scaling up, we're doing this by conducting right now a pilot study, the similar pilot study in Transnistria, post-conflict area, which is very close, by the way, to you, to your border. And also they started in in June, and they are doing very well. So you see, there are two ways what to do with the pilot's results, because so the pilot study results are to be scaled up, to be disseminated. Otherwise, it doesn't have sense, first. And second, I would like to mention that how we at RHTC provide the service via telemedicine. We continue to do this for women who don't want to travel to come to us in Moldova, but also we do this for women who are abroad. For example, in Poland, my last patient was in Poland, can you imagine? But we can do this because we have buses and their relatives buy in Moldova the drugs and send the drugs for medical abortion via the buses to Poland. And then we do the same procedure, the same telemedicine with them. And all practically, there are many women abroad from Moldova who cannot access the services in Italy, in Poland, in Greece, in Germany, they are addressed to us. So we do have this experience, and because the level of complication is so small, and because you are working with a good quality drugs, you shouldn't worry about the level of complication. They happen in every medical procedure, in every medical situation. So, but it's really the same safety, the same efficacy as working in person, and you shouldn't be worried about. And probably like a next step, under the coordination of my good friend, Galina Maestruk, and the colleagues, I see Galina Kvashenko, my good friend and my co-trainer in previous trainings. I think all together you'll set up the next steps of this dissemination of how to use these very good results in your situation, which is especially important. And I would like to finish by the fact that France is the most close to us country which officially approved the telemedicine for medical abortion in their protocols. Also, it's Moldova, another country, but also developed country. Thank you.
Can I?
Вибачте. Дякую, пані Радіка, за таку.
Thank you, Rodika, for this background, for sharing your experience. I know that your experience is really vast.
Galina, I wanted to add. Yeah. Yeah. Thank you. So regarding responsibility and regarding the safety, that's why we collected all this information, and actually clinical research is quite important for the country. First of all, you have experienced providers, you have women who are familiar with the method and who are satisfied with the method. And to see the safety of the method, we collected all kinds of information. And I have already told that all women, they reported taking MIFE as they were instructed. And in addition, I would like to say that medical abortion is outpatient procedure, and women, they are given the choice to take mifepristone, and misoprostol is always taken at home. So there is always some small, but we know that medical abortion is really a very safe and effective procedure. And on top of that, all women, and always, not only in our study, they are instructed where to go, where to seek additional care if there is some kind of problem. And I also wanted to talk about the telemedicine in Georgia. So Moldova was first country in our region who started telemedicine, and we started our telemedicine project in 2021, and we revised national abortion guidelines, and telemedicine is included in our national abortion guidelines. But talking about the telemedicine, we are not talking that it will replace completely that in-person medical abortion process. So some of these steps, for example, eligibility assessment can be done remotely, or maybe follow-up assessment. So not only whole procedure, but in person, some women, they wanted to come to the clinic. So it's just a choice to women.
Тамуна, дуже дякую. Спасибо большое.
Thank you very much, Tamuna. I want to ask the question from Ludmila. What adverse events were observed when using the dose 800 micrograms of misoprostol? Because according to our protocol, it's 400.
During this telemedicine study, we didn't collect those side effects, probably the question is about the side effects.
Yeah.
We didn't collect the information about the side effects, but if we look at the newly revised WHO recommendations, so the recommended dose for medical abortion is 800 buccal sublingual and vaginal route. So they are not. But for the study, we didn't collect it. We didn't collect its side effects. But regarding the adverse events, the serious complications, we didn't have any.
Так, колеги, якщо немає, я не бачу більше в чаті запитань.
Well, colleagues, I don't see any more questions in the chat. If there are no questions, then we will proceed to the next presentation. We have two speakers. They are not having the presentation, but they will share their ideas and impressions of how it works. I would give the floor, first of all, to Ludmila Ivanova. This is the center Oblast Hospital in Poltava, and Ludmila is the main expert, the main obstetrician and gynecologist in Poltava Oblast. Good afternoon, everyone. Thank you, Galina, for an opportunity for us to say a few words. And I'd like to thank Tamuna and all the participants, because Tamuna very well described the principles we used. For example, I was thinking what I'm going to talk about with our colleagues who are online. You know, I would probably emphasize the challenges we had. And secondly, I would like to speak about busting myths and stereotypes. I'm sure you will agree that provision of care to a woman with unwanted pregnancy should be comprehensive, first of all. I mean the access for women both during the first and second trimester. And at the same time, we need to consider the main principles of care, individualization, first of all. So it means that here we follow the needs and the possibilities of a woman with consideration of global challenges we have. And the challenges now we're having war, and previously we had COVID. And of course, the access was limited to the clinics.
To start with, let me pay particular attention to the fact that once we are talking about medicated abortion, then all of those who are practical service providers, we know that this is a procedure where success depends on two elements. Number one would be professional counseling and advice on behalf of the provider, while the second success factor is the preparedness and commitment of the woman to do as the provider has told her to. So once number one and number two are successful, then basically 80 to 90% of success is secured. Why is that important to discuss? If we are talking about the service delivery as such, yes, indeed, we have to admit that this can be rendered under the protocol 1177 in terms of outpatient care. It can also be provided in the inpatient care, because I do know that some women are hospitalized as inpatients for the benefit of the misoprostol administration. Some providers still believe this is an important thing to do. But now, thinking of the service modality, we today live in a modern society, which is full of different telemedical opportunities and technologies. And as Dr. Tamuna explained, we can and should use the best of technology available, starting with the smartphone, different applications and messengers, which can help us in delivering this service effectively. And this is a wonderful option to face, particularly in the context of some security challenges, environmental challenges, or any other challenges we might be facing. On the other hand, when we started our work, I, both as an organizer of this project as well as practicing clinician, I had to make sure there's appropriate regulation of all these tasks and objectives for TMA within the regulatory field and as provided by the national legislation. So first of all, we have requirements from the National Health Service of Ukraine. If you look at the contracts which are signed by NHSU and your facility, then that would be first and foremost preparedness of any healthcare facility to provide telemedical services in different areas. And this will be a very big bonus in your favor in terms of arrangements with the NHSU. Secondly, what do we have allowed by the national service? And that would be ability and capacity to use the e-health system, which is online counseling, to have reimbursed. So this is quite normal and acceptable for us to record and report on each such counseling sessions. Also, it's convenient for the patients to register online for such counseling sessions. And once you deliver such service, and respectively the procedures of follow-up care, which can be used for reporting the respective medicines and actions to be performed. And also, speaking of the administrative elements involved regarding the drug procurement, then as part of the package number 9 of outpatient care, any healthcare facility which can and actually is providing telemedicine services is eligible for procurement of such drugs. But this is important to make sure that these drugs are available in the Ukrainian domestic market. I mean, there is marketing authorization provided. They are registered for domestic use. Then another important factor to pay attention to is appropriate documentation and reporting, because as we only started piloting the project, we have designed the informed consent form to take part in the TMA operations. So telemedical abortion is a service. This is a modality to provide a service. And here I'd like to ask another question and answer it immediately to explain you why we have only 4,800 abortions performed so far. One of the elements of our reality is that all of us have the order 423, which delineates and stipulates the respective reporting process and documentation to be filled in on our site, which includes a medical chart for medical abortion with lots of instructions, which provides that it should be completed for both inpatients and outpatients. In the point 24, there is a section for medicated abortion. Why is that important? When a woman presents to your facility, it's not only reporting form number 25 that you have to fill in, but also the special medical chart, including the informed consent to perform a medicated abortion, including all of the notification dates and requirements. And then, once you have performed this procedure, you have to hand out this medical chart to the supervising officer, who will include it into the quarterly medical statistic report to make sure that we have the annual report number 13 completed, to have all such cases accounted for. But what is happening today? Today, a woman presents to a clinic. We provide a counseling session. She decides to go for medicated abortion. She buys the medicines independently. We report it in the form number 25. administer the drugs, and close the case. And this data doesn't go anywhere. We cannot see it in our cumulative medical statistics. So please pay attention to that. If you provided the service of medical abortion without filing all these documents, that is a crime, because this case is not accounted for. So this is important to emphasize. But what else did we have to do in terms of facing those challenges and improving the regulations? All those women who actually presented in as members of our as participants of our research, we performed everything in full compliance with the legal requirements. I mean, the report number 25 was completed. The medical chart for medical abortion was completed. We have reported such cases, including the electronic reporting systems. Additionally to that, the informed consent was provided on behalf of these women, as well as seeking and enjoying telemedicine services. If you ask a question whether it's a viable system or not, I will say yes, and I'll be supporting it, voting in favor by mouth, my hands and feet. But another important fact is preparedness of a woman to get involved. Well, let me paraphrase it. There is another important thing to emphasize. When speaking efficacy, when discussing efficacy, the high quality counseling is also one of the fundamental prerequisites of success. But let's discuss who should do that. We understand that counseling should be provided by the highest possible professional you have, because this counseling, in terms of preliminary information, and then taking it to follow-up support at week 1, at week 4, and so on. Indeed, there are some questionnaires and there are some instructions what to do and how, but communication skills, the soft skills of your professional and service provider is very important. Do remember that communication is a bilateral process. This is not just giving out some facts to the woman. This is also asking questions, addressing some of her concerns. And that's where Tamona was so correct in emphasizing the fact that, yes, indeed, women were satisfied by the fact they don't have to waste their time visiting the facility every now and then. And confidentiality was observed. This was also important. Also, they didn't have to um, ask for permission from their job supervisor or somewhere in an education facility for the benefit of attending the counseling session. So this was also beneficial. But in any case, they were well informed. All of them signed informed consent form. By the way, informed consent can also be done in a remote manner using those messengers and email. And this could have been performed following the preliminary counseling session. And we were filing this in a PDF version using those different messengers. And today, our smartphones are smart enough as a device to enable electronic signature application and mailing it back. Also, speaking of the pregnancy testing and confirmation, this is really important, and there are respective requirements in the Ukrainian guideline, in the research protocol, as well as international guidelines. So that definitely has to be performed and send either ultrasound examination report as a confirmation following up, or this could have been arranged by means of a pregnancy test, either using urine or blood. But in this case, we have to exclude the risk group of ectopic pregnancy. Yes, that is definitely important to remember. Another implication regarding the phone counseling sessions. On behalf of the provider, let me start with that aspect of this service, because you have to be experienced and even trained to have the appropriate communication skills to be able to do such remote consultation. Also, to inform the woman, to discuss the possible counters or indications, to assess her preparedness and commitment, and decide respectively. And also, speaking of the follow-up, this is very important to rely on the nurses only, because your medical nurse, she also has a very clear line of performance and area of responsibility. She can help a lot in terms of filing the documentation, and she also can contribute to the counseling, to provide instructions along with standard operational procedures and instructions. So she can, and any nurse can do a lot, not necessarily clinician. Now, speaking of the drugs availability, I mean, procurement, supply, and everything else. Thank you, dear Galina, but we received high quality drugs, both the MIFs and MISO. And it's not the matter of advertising these particular drugs, but we have not seen any well-manifested adverse effects. This is a good thing. So, my dear colleagues, do distinguish between complications and adverse effects, because it really depends whether or not it results from the drug administration. And whenever talking about some minor nausea or something else, then definitely this is an acceptable adverse effect, which might happen, but it's passing without any particular interventions on your behalf required. Now, speaking of the drugs delivery or dispensing to the woman, if a woman decides to come to a clinic, then definitely she can collect her take-home medicine. Also, we were relying on the courier delivery. Another part of the drugs was mailed by Nova Posta mailing service. And speaking of any problems, we never had them. And another important thing is, and that should become part of your counseling, you have to identify the indications or counterindications, exclude any risk of ectopic pregnancy, discuss them appropriately, answer all of the questions a woman might have. And there is a lot of published materials, including even in the body of the informed consent form, where all of the major questions are answered. So again, we can expect some kind of side effects or complications. So you have to inform the woman about the fact that they might occur, but also provide clear instructions where to go, whom to call, and what to do in case something actually happens, including connection with the service provider. And again, we have established a routine procedure for our professional communication with the peers. And by the way, such training events and conferences are also helping for us to learn from each other to be better prepared for any kind of situation. But most importantly, all of that now is within the legal field in our country, which also provides you not only with the answers to the question, but also with solutions that you can apply. There was a question about the route of administration and the dosing. So, my dear colleagues, please read the Order 1177.4, administration and dosing, clearly suggesting that administration dose per oral, transbuccal, sublingual, vaginal, all of them are well described, both for outpatients and inpatients, and there is freedom of discretion for you as a provider to decide the best fit opportunity in a particular patient case. So now we have lots of clinical experience generated for us to rely on. Now, speaking of the 800 as the dose for transbuccal administration, I want to assure and reassure you that except for unique and exceptional cases resulting in some nausea, there were no other side effects. Because in case of transbuccal administration, the absorption does not affect the liver. and the peak of the dose is elevating quite gradually, and it's sustained for the appropriate period of time to ensure the most effective evacuation of the conception result and elimination of any kind of adverse effects. Dear Ludmila, thank you for being so focused and detailed, but we have only 3 minutes before our next session starts. Yes, thank you. Thank you for keeping me on track and time. And not to steal any of your time, let me thank you, dear Ludmila, because in your detailed overview, you have potentially anticipated and answered all of the possible questions. And at 3 p.m. Kyiv time, we are expecting Dr. Beverly to join us. This will be 8 o'clock in the morning in New York. So we hope this will be an early and productive start of the day. But Vladimir, if you have anything else to add, well, this was my pleasure to listening to my colleague, and I can't but agree with everything she said. And I also would like to reinforce that the most important priority would be high quality counseling. My dear colleagues, do remember that one of the first requirements of our Executive Order 1177 has a wonderful statement. After delivering the counseling about the medicated abortion, there should be no concerns, doubts, or questions remaining in this woman case. And you as clinician, you as service provider, including myself, you should train and perfect your communication skills, because once you discuss everything with your patient, including possible complications and adverse effects, that means that the woman will be well informed. Also, she will be invited to give you a call any time of the day or night, which is a regular thing in our OBGYN practice. But in case of TMA, I don't remember a single call in the middle of the night, frankly speaking, because as a matter of the right, even if there is some bleeding, but they are well informed and they understand what is actually happening. They know how many hygienic products to use, then usually there are no misunderstandings happening. And also, telemedicine is an auxiliary component which helps us to extend the very spacious capacity of TMA as a modality and service. And also, speaking and working in our working group on drafting the new clinical guideline, which will be a logical, how to describe it, follow up to 1147. And fundamentally, this protocol, this guideline will have all of the most advanced and recent pieces of information.
And this protocol includes very detailed information about telemedicine. And I think with the new protocol, the problem of safe abortion, at least in our country, will be not as will be solved. Thank you very much, Vladimir. I see somebody raised their hand, some user called Galaxy, but this is the name of the telephone. I can't see it now. I'm very grateful to you for your comments. I think when we have a time for discussion, I would like either Valentina or Olga Kwashenko or Grishchenko to speak, because they were involved from the very beginning in the working group, and maybe they will share their vision, their expert vision, what is the future of telemedicine in Ukraine, because this is really reflected in the draft protocol. So now it's 3 p.m. in Kiev, and we are very happy to invite our esteemed Professor Beverly Winikoff, who did huge work for Ukraine, starting in 2005, when she very actively was helping us to promote medical abortion, so that all the modalities of MA were woman-centered. And she must be the first person who put on the top not the clinical interests, but the matter of safety and comfort for the woman. That's why, Beverly, the floor is yours. We're happy to see you, and we hope we will see you in Ukraine. Thank you very much.
Hello, can you hear me?
Yeah,
Yeah,
we hear you. Yeah,
okay.
we hear you.
I'm going to, my slides are in Ukrainian, but I am going to speak in English. I apologize that I don't have fluency in your language, but I do have very fond feelings for your country, from which my grandparents emigrated to the United States more than a century ago. So I feel my roots when I see you here. Thank you for asking me to talk with you. First of all, I want to introduce Gynuity Health Projects, which is our organization. And we have been working in many areas on safe, effective reproductive maternal health care technologies. And we are very concerned about women's acceptability, or what they need and want, not just what the science has proven. So we had a very long experience now with pills for abortion, and it has taken a lot of our time, and it's a lot of our work right now. We do research on medical abortion, postpartum hemorrhage, preeclampsia, hypertension, and pregnancy and contraception. And if you want more information, the website is on the screen. Am I changing the screen, or are you, Galina? Galina? How do we change this? Okay. That's just what I did.
You say next. You say next, and
okay. Okay.
Next.
Okay. So next now. Again, next.
Next.
Yeah. Oops. Just for background, Gynuity has a long history in telemedicine for medical abortion in Eastern Europe and Central Asia. And you can see here some of the products that have been published from different kinds of studies that we've done in the region, including places like Moldova, Georgia, Uzbekistan, and Ukraine, of course. And we are still working in the region. And despite the situation in Ukraine, we're very much, we feel very much close to the work in Ukraine. And I just want to say personally how much we are impressed by the way the Ukrainian people have been standing up to a really terrible situation. And we're very much invested in seeing you persist and and continue in your country's development. So we are very, very happy to be able to talk with you today and also to share projects now and in the future. So we've done a lot of work, as I said, in the area, not just in Ukraine. Some of our papers are already printed. Next. Next.
Следующий. Андрей, следующий.
And again, this is 2 papers that are in the literature already, but there are others as well. Next. Yeah. We've been instrumental in helping countries change their abortion guidelines, including in Moldova and the Republic of Georgia. And we are continuing to work on telemedicine in Ukraine, Uzbekistan, and Azerbaijan. Next. Okay, I think it's next yet again. Yes, next again. One more. Yeah. The World Health Organization abortion care guidelines of last year were revised to include telemedicine approaches to delivering medical abortion care. And this was a recommendation that was brand new last year, and now it's ensconced in the WHO recommendations, that there should be options of telemedicine as an alternative to in-person interaction with healthcare workers to deliver medical abortion services in whole or in part of the service. And it includes recommendations to assess for eligibility for medical abortion, counseling, administration of medicines, and follow-up care, all through telemedicine, meaning that people do not have to come to a clinic at all to have a service. But what I want to contribute now are some of the things that we have done outside Eastern Europe, specifically in the Western Hemisphere, in the US and in Mexico. We've had some very good big studies also coming to the same conclusion that women want this kind of service and that it's easy to implement and very safe and effective. So next.
Next.
Yeah. Teleabortion is the name of our telemedicine project for medical abortion. And it was started in the US. Next. It's direct to patient care, in which the patient doesn't ever go to a clinic, except if there's a problem. And the patients can communicate electronically on the internet with the abortion provider from the patient's home. If there are screening tests needed, they can be done locally. They don't have to go to any specific center or clinic. And if the eligibility is confirmed, the clinic sends the abortion drugs by mail or by courier, depending on what kinds of facilities are available. And then there's a follow-up contact in a week or two after the person has used the medicines. We found that telemedicine for abortion really corresponds well with the patient's needs. And people want what people want out of an abortion service is sometimes better achieved by having a distance relationship. So people can have privacy. They can fit their daily chores and things they have to do around the medicine, and it can fit in any time that's good for the patient. It reduces the travel time, may reduce the cost of the abortion altogether, and it happens to be very useful for COVID and distancing, social distancing. Next. So this is the United States, and we have our project was done in green, all the states that are green on the map. And so some of the states were mailing drugs from one state to another. That's the way the arrows are. But in other states, they were only using it in their own state. So if you can see Georgia, which is in the south, I don't have a pointer here, but I'm trying to point, but anyway, it's all the states around it are red or not available for abortion services now. So they were one of the only areas in which a woman could get pills in that region. And in some places, the pills were sent between states, but in other places they were within states. But this is just a feature of our country that doesn't really matter where you are. Next. Okay, the first 973 packages that were sent out, we found that there was a complete abortion, medical abortion, in 96% of people, and those people didn't have to have any physical contact with a physician or a clinic. Only 4% needed some kind of information or tests or completion with a visit to a clinic. Next. Satisfaction is extremely high. The first bar is very satisfactory. The second bar is satisfactory, and only 1% of people found the kind of procedure to be unsatisfactory. So 99% of people said that they endorsed this and actually quite enthusiastically. What did not happen, which is very important as well. Next slide. Yeah, there were no delayed treatments. There were no breaches of confidentiality. There were no lost study packages, and there were no use of drugs by someone other than the patient to whom the drugs were mailed. So people are always skeptical that these kinds of services can work, but apparently even with hundreds of people, we had really no problems at all. So the next slide is shows the growth of it, and part of the fact is that we didn't have enough manpower, woman power, to expand our work in different states. So, but all during COVID, this was an extremely helpful way for people to be able to get medicines for abortion. We also did next. Yeah, we also did qualitative work, one-on-one interviews with study participants. We did 45 interviews at 7 study sites, some during COVID and some after, and some before, sorry. These interviews were trying to understand why people chose teleabortion, why did they want to do it in the first place, and what their experience was when they actually did it. Next. I put this up I'll leave it to you to read, but what was one woman's synopsis of why this was a type of service that she really appreciated. And I'll let you read it in Ukrainian. And this was a type of sentiment that we found over and over with this kind of service delivery. And then we've also done one in Mexico that's different because it's a different country with different laws and different language and different culture. But interestingly, pretty much the same kinds of responses from doctors and from women. So I'll just give you a précis of the Mexico work that we did next. Yeah, which we called teleaborto, which is the Spanish of teleabortion. It was done by our employees in Mexico with Mexican clinics. Next. Just to remind you exactly where Mexico is compared to the US, it's the next country south. Has a quite long border between the US and Mexico. It has a lot of political salience because there are a lot of people who are crossing the border with no papers. So it's kind of it's in the news a lot for the US. But it's a quite different culture and a different language and different history of abortion, which was only recently approved to be legal in Mexico. But they have tried to catch up to the US, and I think they are very close to having services the way we do here as well. So they started with Mexico City, the capital, which is sort of in the south, in the center of the country. It was introduced originally 16 years ago. Their next slide, please. This is on the next slide. Next slide, yeah. So their legal limit is 10 weeks for medical abortion. And even in women who are from states that don't have government clinics that use this, they can travel, people can travel to other states and get it. It's not illegal to do that. So and there are a lot of people seeking it. So it's become pretty well known. Next slide. Right. So this is the schema for how the service is offered. They have an initial contact from a patient, and then a distance, like a phone call or a screen interview, which evaluates whether the eligibility allows the package to be sent. Then the package is sent, and then there is a phone follow-up 1 to 2 weeks later. And of course, if there's any problem during any of this time, the person can contact somebody and be helped to get to a clinic. Next slide. Yeah, this just shows you what the ages are of people who use the service, and as you can see, mostly young-ish people, and also their education. And again, a lot of people had more education, and I think that's partly because they read the newspapers or they're more informed about new things that are happening around them. They're probably less rural, more urban, and more educated. So, yeah. Next slide. Here you can see, however, that there are people who requested the teleabortion, in other words, mailed drugs, from almost every one of the states of Mexico. It's not confined to the capital, which is the star in the middle of the screen. But there you can see that in even all the other states of Mexico, people have contacted the people in Mexico City or in the other state where they had a provider, and the product, the 2 pills were sent by mail or courier. Next. So you can see here how diverse the distance from the provider was, and that almost half of all people who use the service were at least 500 kilometers from the provider. So this is a really a good test of the fact that it serves people in places who could probably never come to the clinic. And we were very pleased to see that kind of a response. Another thing that we worried about, and that I think also the clinics worried about, was how long it would take for packages to come. Next slide. So you can see here that most of the, almost 3/4 were delivered with 5 days or less time. And that's really helpful because we don't want people to delay abortions and get further along in gestation. So I think they did an excellent job of sending the things out quickly and having expeditious services to courier the drugs. Next. Okay. Most of the people had their tele-evaluation, in other words, that they were eligible for the drugs to be sent to them. The largest number were by phone call, but the follow-up was more likely to be on app. I don't know if there's any significance to that, but I guess maybe being more familiar and having access to the clinic, after several interchanges, they probably went right directly to the app. But in any case, they're very wired. Let's say in Mexico, a lot of people have access to the internet. Next slide. Okay. So what happens if somebody wanted to go to a doctor? Well, they would go to ones near them, but very few did. As you can see here, 13 people went to someone else, but they weren't even given any treatment. There's just reassurance. 24 people out of almost 900 had an NVA, and 12 had DNC by a local practitioner. That doesn't mean they needed it necessarily, but it's what happened. But still, it's very small number of the people who started with the pills that were mailed. Next slide. And when we asked people how they liked the teleaborto procedure, the overall satisfaction was very satisfactory or satisfactory and 1% unsatisfactory. 100% found it satisfactory or satisfactory with remote communication with the provider that they had, and would recommend, almost 100%, 98% would recommend teleaborto, which is this service. to a friend. So there was a obvious appreciation of being able to have an abortion this way. Next slide, please. So what do we see in the future? We're going to try to expand the service to reach vulnerable communities and populations that we haven't been able to do as well as we would like. And we need more communication strategies in some places, especially when there are rural areas. Access to technology and internet is a limiting issue in poor parts of the country, and also, I suppose, in other countries that are poor or have regions that are poor, it's a little bit more difficult. We are collaborating with local NGOs to disseminate the service among the native populations who live in rural areas, migrants and people in situations that are dangerous to them, like in domestic violence types of relationships, etc. And those are a little more difficult. And then I think the people in Mexico and the people we have working in the US are trying very hard to get these telemedicine models into public reproductive health care services, not just as research enterprises. So we think that we have done a good proof of concept, and now we need to spread the word and have allies and colleagues who are going to take it from here and to their own countries and own medical systems. And we're very happy to have any questions now or later. If you want to contact us, we're here and happy to communicate. And I really thank you very much in the midst of all of what is going on in your country to be able to put on a seminar like this. And you have all our best wishes. Thank you.
Thank you very much, Beverly, for a wonderful presentation. I think that we now start already the session for questions and answers. If somebody have comments, questions or answers, we are open to this session, I think. And also I have a question for our also participants. And maybe we will, давайте почнемо з запитань якщо є...
So let me suggest with the live questions and answers first, just in case there was some uncertainty or some additional comments I'd like to suggest regarding the content of the presentation.
We don't have them yet. В нас ще поки немає запитань. We don't have them yet. Я хочу надати слово.
In that case, let me also share the floor to some maybe improvised contributions to a prominent professor, Valentina Kvashenko, who was our project coordinator in Donetsk region. She was one of the launchers of the once wonderful project, and she covered the entire Donetsk Oblast with her efforts. But my question would be, dear Valentina, what do you think of the development opportunities for using TMA in Ukraine? Thank you so much, my esteemed colleagues. This is my pleasure taking part in this very interesting conference, and I'm happy to admit that all of our pioneering efforts back in 2014 with Dr. Zhilka and Moisenko, well, Moldova was the first country to win in this project application, and then we joined in the next phase. But this is important that this initiative is developing, and the research you did and the results you have and findings you have identified are really very promising. And before I proceed, let me reflect on one of the questions, which was about dosing of misoprostol. I mean the 800. But if you look at the new standard, speaking of the first trimester, then in line with the latest clinical guidelines, which have been translated and adapted for Ukraine, they will be officially published soon, so you will have all of your questions answered. But now speaking of our project, which was quite a remarkable effort indeed. And I would like to particularly thank Rodica Commandant, because she was one of the initial mentors and trainers working with the OBGYN specialists and then following up in Kyiv. And this was the result of her effort that this project intervention was so productive. But then, unfortunately, in 2014, particularly speaking of Donetsk Oblast, a big part of which was occupied, which resulted in the termination of this project. Nevertheless, Raisa continued to use this model. So, and thank you, dear Galina, for supporting this intervention. And then Ovsyannik she continued working with the second trimester opportunities. Also in Kyiv Oblast, as well as Kyiv City, manual vacuum aspiration is quite broadly used. And many people are calling me for advice, and also in case of some complications, asking how to use alternative types of medical abortion. And indeed, there were other efforts and attempts seeded, and now they give sprouts, and the initial initiatives develop into something bigger. I wish we started this before, but finally, the clinical guidelines, which are quite outdated, being published in 2010, in 2011, they have been revised. And now we fortunately have this new edition of the WHO guidelines, which have been translated. We also translated the INES protocol as well. Olga Grishenko helped with the translation. But we decided to use the WHO guidelines because it's designed for the countries like Ukraine. I mean, we have limited capacity, we have limited income, and we can't have full access to some more sophisticated techniques. So I would like to thank you for your never-ending efforts in terms of developing the telemedicine, although you didn't call it telemedicine, but we were using remote counseling and follow up with our patients. We were using distant shipments over the distance to deliver drugs to the patients. And today, working also in a private clinic, we do have cases of women who ask about abortion, but no, we are trying to counsel them appropriately and also advocating for prevention of undesired pregnancy as the key intervention. But setting that aside, we were positively impressed by the data you reported. And one of the interesting factors before starting to work on these standards, this was a very helpful finding I mean, the fact that you found the latest statistics, because we do have official reports of 2016 and 17, but any more recent data was not available. So thank you for persistence in looking for the data and finding it. Further on, as we were drafting those standards, we wanted to find the answer to a question how to legalize, how to provide legal grounds for such abortions in Ukraine. And the fact that now we have the new legislation about prescription-based dispensing of the drugs, because definitely these drugs cannot be dispensed as over-the-counter drugs in public institutions. Women have to buy these drugs at their own cost, even while having the respective prescription, but having them provided free of charge would be also beneficial for benefit of the patients. Also, this is important to document each patient case appropriately, including the patient chart in both for outpatient care and inpatient care, because indeed inappropriate documentation might be a crime, so we should not admit it happening. So that is one of the subjects that we have to talk about in our follow-up workshops and seminars. Hopefully that rolling out this project to a bigger scale of implementation will be our next step, because we have to make sure that this service is commonly available like in other European and American settings. And also, I'd like to thank you for such a highly interesting webinar, not just a webinar, but a conference, a marathon-style event inviting international speakers. And I remember we did have a webinar in Turkey, but that was 2012 in Istanbul. Yes, and then I do remember the Tbilisi event when we had such a collaborative communication opportunity. But that seems like ages. And now I'm happy to see all of you so full of energy, so young and handsome, like you've been a dozen years ago, and still committed and professionally motivated. Thank you so much, dear Valentina. And with that, let me ask a question to Professor Beverly.
You show the map of United States, and some of them are in dark red. Most of states are in a dark red, and only three, some of them are in green. Can you explain more about what does it mean? They are prohibited to participate in such kind of research, or it's internal regulations? What does it mean?
So, yeah, we have a very complicated situation in the United States now. I don't expect anybody outside the United States to understand it. It's completely crazy. We don't have a national law about abortion. Most abortion regulations are within states. And so the possibility for different kinds of services are really within the state's purview. The state can allow abortion or not. And there are some states now, I think, that are not allowing any abortions for any reason at all, including the health of the mother, anything. And some say only till 6 weeks, or some say till 20 weeks or 15 weeks, or so it's like a quilt, a patchwork. It doesn't, there's no standard for the country now. Every state has its own regulation. So and I think that we could not have done it in the states that are red. Not all of them have bad laws, but they don't have some of them who have reasonable standards, but they don't allow mail-in to drugs. So it's just, there's a lot of different things going on. I'm sorry, it's really a mess. And even in the US, we don't understand what's going on. So yeah.
Thank you very much for explanation, because many people because many people don't maybe understood what does it mean dark red and green.
Yeah, in this case, the green are the places where we were able to do it, and then the not colored, we could have done it, but we just didn't have the manpower or woman power to do it. We didn't have enough people to do it. And the red is where we couldn't do it because of legal concerns, which is not the same exact thing as can you do an abortion in that state. It's that we couldn't mail drugs in that state. So yeah, there are different levels of problems in the states, but we have 50 states and it's like 50 countries. So yeah.
Так, я думаю, що колегам зрозуміло, що це означає. Це може не тому, що там заборонені.
Yeah, I think the colleagues have understood that it's not because abortions are prohibited everywhere, but the mail-in was not could not be done. So we have a little bit of time left for questions. Colleagues, if you have any additional questions to our speakers, to members of the working group, to our international experts, you have a chance to ask these questions. And I think if there are no questions, then we will draw some conclusions and finish. So I see in the comments, thank you for very interesting answers. Some smiling faces.
I'm sorry about speaking the second time, but I cannot say hi to Beverly and say how glad I am to see you and happy. And well, I just wanted to pay tribute to Gynuity Health Project because let's be honest, we do have medical abortion in the region because of you, Beverly and Gynuity, and all the projects and all the implementation study and all the trainings. 2003, you organized the training for us in Moldova, in Paris. So I just want to, let's say, improve your mood.
Oh, thank you.
Yeah, because of this bad situation in the States. Instead, look at the region, how well we progressed from the very small, very shy introductory studies toward the telemedicine medical abortion. I'd like to congratulate you. You should feel proud. And maybe United States right now can look at the region and take the example. So maybe this is the future. Yeah. Thank you very much, Gail.
Thank you so much. And Tamuna, who is our person for the region, is on this on the call also. Yeah, and sure. She's been doing all the legwork in the region. Yeah, sure. She's been wonderful at communicating all of these things. I also, if you can see this is the map, not like the map I showed had to do with our project. This is the actual legal map, which goes in very many colors, but it goes from dark green to completely accessible and no particular laws stopping people to have abortions. Then it goes through lighter green, then yellow, then orange, and then the dark red is where there are really no abortions allowed now. So now you can see sort of a more gradation. This is the legal status, not the issue of sending pills. So yeah, you can see it's a mess. So we're still trying to figure out how to deal with our own country. So I hardly feel like we're expert in telling you what to do. All we're trying to say is there are a lot of ways of skinning the cat, as they say in English. We can do things and you can get things done even in difficult situations. So, and we'll help.
Thank you, Beverly, very much. I'd like to say you also some very, very warm words back, because you grow up a big number of real experts in our area, because you was a pioneer and you still a pioneer, and we grow up due to you, because of your trainings, because of your conferences, because of our trials. You help us to, as I told, to see the problem of women like a central person in provision of abortion, not like medical problem, like a women problem. And then doctors are used to help her in a very appropriate way. And this is working. And we all are here, actually, your children, your students, your real fans, because we are from this generation, from your big support. And really, in this very difficult time for my country, for nearest countries who are near Ukraine, because it's a fire, and we are in position when this fire is very dangerous. For us, it's also a big hope for improvement of situation, for really big changes. And I'd like to maybe to finalize and say to you real great appreciation of your long-term work. And also to Tamuna, as always, big friend of Ukraine, big, supporter of Ukraine, who makes a lot of changes here still 2007. And special my thanks to Radika, physically traveling through all Ukraine, participating in many different events, many different, sometimes not easy events. Sometimes events like ban of abortion protocols and many others things. Я думаю, що всі мене почули завдяки перекладу. І, власне, якщо немає...
I hope that everybody heard me with the help of translation. And if you have no additional questions, let me thank you for the comments related to the conference, for your interest in this conference. There are a lot of comments like that. And your hearts in the chat, they really make us feel warm. I want to say that Ukraine is a unique country, and we are talking in different languages, but what unites us, because here there were some comments about the Ukrainian language, but what unites us is the fact that we're all Ukrainians. We work for benefit of our country and for health of our women. That's why let me thank you all, Valentina, Volodymyr, for your great contribution. I think we will be closing this conference. I probably said all possible thanks to all our experts. I'd like to thank the participants who just allocated 3 hours for this discussion and for participation. This is really pleasant. And now we are looking at the opportunities to use our developments, and we will make these presentations and materials available to you. But I think the greatest gift this year will be approved guidelines and clinical standards. And telemedicine will be a part of these standards, that's for sure. And then you will see it for yourselves how to put into practice this knowledge, either partly or through telecommunications, etc. But now, once again, we open a door for you to novel approaches. So thank you very much. And I also would like to thank our Andriy and Irina for technical support. I'd like to thank the company which hosts this conference, and of course Gynuity, which made it possible, not only by funding but also by assisting with the research, with the content. All the best to you. Peace to Ukraine, and I wish you wonderful prospects for all of us. We will overcome all the difficulties and we will win. Thank you and all the best to you. All the best. Thank you.